Welcome back, everyone. We're going to continue with toxicology by looking at organophosphates and cholinergic toxicity. Organophosphates are a major component in many insecticides. Exposures from organophosphates can be by suicidal ideation. That's typically if they are ingested, or accidental agricultural exposure, or seen in the manufacturing process. For the pathophysiology, the mnemonic dumbbells can be helpful, and organophosphates exert their effect on the junctions of the nerve cells, particularly within the autonomic nervous system. Patients will experience diarrhea, urination, meiosis or constriction of the pupils and muscle weakness, bradycardia, bronchospasms, bronchorrhea or discharge of mucus from the lungs, emesis and vomiting, lacrimation, seizures, salivation, and sweating. Essentially, everything is wet in the body. You see excessive digestive enzymes being secreted, excessive sweating and eye watering, and that's going to be that hallmark presentation for organophosphate toxicity. In moderate to severe organophosphate poisoning, we'll see things like muscle fasciculations. We would expect to see severe respiratory distress, flaccid paralysis, and seizures. For assessment and management for organophosphates, the primary treatment is going to be remove from the affected area and then decontaminate the patient when at all possible while maintaining the airway. The excessive secretions that occur during organophosphate toxicity create significant and profound airway problems, and copious suctioning may need to be administered. Long-term pharmacologic treatment, so once the patient has been decontaminated, IV atropine should be given in copious amounts. And then the further antidote is pralidoxamine, which is infused with normal saline. So for basic level providers, if you suspect an organophosphate toxicity, you should engage in the decontamination and airway support process while you await for ALS arrival and the administration of 2-PAM chloride or pralidoxamine and atropine sulfate. Once paramedics arrive, or if you're a paramedic provider arriving on scene, make sure that you apply the ECG monitor pulse oximetry and capnometry, and immediately transport the patient. Be mindful as well that exposure may be secondary. So first providers that arrived on scene, first responders, may have had secondary exposure to the patient during the decontamination process and may need to be treated accordingly. You likely will not have enough atropine on your truck to treat one patient, so it's important that if you've got access to the 2-PAM chloride, that's also made available to you while en route. Notify the receiving facility that you've got a potential organophosphate toxicity, as they'll probably engage in decontamination again once you arrive.